As an oncologist, I don't see a patient now until they've had biomarkers done. In lung cancer, it's critical that we know a patient's status for EGFR, ALK, ROS1, and RET, actually more than ever for RET, given some of the new inhibitors that are coming down the pike, and also PD-L1. And actually, I'm very fortunate. I work with David. We actually work together at the Yale New Haven Hospital, the Cancer Center. We actually very early on, working with David, he developed the PD-L1 assay, so we have that as well. And it's very important to have that because now lung cancer therapy is more personalized than ever. And we need to know if someone has a molecular driver and treat them that way, or if not, I find the PD-L1 status to be important. Even now with so much of the chemotherapy combos being used, it's still important, in my opinion, to know PD-L1.
So I think this is really an exciting time for pathology because historically we've just given a pathologic or histologic diagnosis, and now we need to know more than that to manage the patients, and especially in lung cancer more so in other cancers. Breast cancer was the first place that we really needed to know molecular information, but now lung cancer has far exceeded that. And it's not just the DNA sequencing information. We need to provide Roy and his colleagues with the EGFR status of the patient before he even sees them, as you heard, but also other genes. And in fact, every meeting, it seems like there's a new gene that we need to provide. So we have to be a little bit nimble in the way we provide the genes and ready to provide more genes. And then what was a real breakthrough just a couple years ago was with immune therapy. There's actually a companion diagnostic that's an immunohistochemistry companion diagnostic. The last time we had one of those was in 1995, a new introduction of an immunohistochemistry diagnostic. So this is really exciting for us. That's why I worked with Roy and we brought online the FDA-approved companion diagnostic for PD-L1 assessment for lung cancer patients. And we really, thanks to Roy, we were really one of the first places to bring it up and use the test routinely, certainly in our area, but even nationally. And now pretty much, I think most sites are doing it. I think probably 80 to 90% of the sites are at least providing it, or they really need to have this information for the oncologist somehow. How difficult is it for us as pathologists to actually provide the constantly increasing amount of information that the oncologist needs to manage the patient for immune therapy? And in fact, what we see is that the specimens are getting smaller, and the demand for information from those small specimens is increasing. So in some ways, we can do that by having an efficient use of the tissue. In other ways, we are stuck, and that's a problem. We are always, need to request more tissue in order to provide all the information that's necessary.